Assalamu alaikum. I'm Dr. Sara Khawar, working as an assistant professor in University Institute of Physical Therapy, University of Lahore. Today, we are going to learn about somatic dysfunctions. So the term somatic dysfunctions is described as impairment in functions in the neuromusculoskeletal system that is of biomechanical in nature. This is the term in contrast to the disease that is of non-mechanical and pathological in nature and that requires expertise of the medical physician for diagnosis and its management. It develops as a result of tissue pathology, but the pathology is of mechanical nature and can be traced to non-systemic causes including macrotrauma, cumulative microtrauma, and immobilization. Once the disease is ruled out, that is based upon thorough history and physical examination, the next step for the manual therapist is to determine the three of the McKenzie's syndromes that more accurately describe the patient's condition, that are postural, dysfunction, and derangement syndrome. This classification is very important as it helps to establish direction of management of the patient. So in this case, we do not consider the terms postural syndrome, as postural syndrome implies the normal tissue that is abnormally placed. Theoretical description of somatic dysfunction describes that there is a scar tissue that is because of the pain and impaired muscle function. That impaired muscle function leads to asymmetry of the muscles, and this asymmetry of the musculoskeletal system further leads to disruption of the rhythm and harmony of the body mechanics. The presence of somatic dysfunction is usually asymmetric pattern in nature. It restricts the motion in one direction and allows the motion in the other direction. We use the term TART to describe a somatic dysfunction. So the TART stands for change in the tissue texture that we'll discuss later, asymmetry in muscles, restriction in movement, and barriers, and we also discussed about the tenderness of the muscle fibers. When we talk about the acute and chronic conditions of the somatic dysfunction, we can say that in acute condition, there is edema, boggy swelling, and there is hypertonic tissue. When the tissue presents us in a chronic condition, it is fibrotic in nature. It is cool and dry and hypotonic. If we talk about the asymmetry of the tissue, we can say that asymmetry is always present both in acute and chronic conditions, but there is movement compensation, tissue compensation in response to the chronic pathology. Tissue restriction or the movement barriers are always present because of pain and impairment in the motion. They present with less pain in chronic condition. So as we discussed that there is asymmetry, this asymmetry results in some of the muscles to get weakened and some of the muscles to get tightened. The weakened muscles are adaptively lengthened and the shortened muscles are adaptively shortened in a certain position. This leads to neurophysiological makeup disturbance of the muscle that affects the overall length-tension relationship disturbance, and also the angle of pull is changed. There are some clinical features of somatic dysfunction. One of them is hypertonic muscles. Hypertonic muscles, as described by Janda, are usually responsible for posture upright position. These muscles are very much tend to become tightened and hypertonic when in pathology. They develop contractures, but they are less likely to become atrophied. On the opposite side, when we talk about the other muscles, which are not hypertrophic muscles, or they are not postural muscles, we can say that all other muscles are phasic muscles. These muscles are the ones that don't become active very often and instantly. These muscles are very much prone to become weak and inhibited as response of pathology. Here we can say that all the muscles that are responsible for posture upright are prone to get tightened, and they are hypertonic, so they become shortened. And the muscles on the opposite side of these muscles that are working in contrast to these are called as phasic muscles, and they are prone to become weak and lengthened. Some muscles are gastrocnemius and soleus muscles, tibialis posterior, short hip adductors, hamstrings, rectus femoris, iliopsoas, tensor fascia lata, piriformis, erectus spinae muscle, quadratus lumborum, upper portion of trapezius, calcaneus, sternocleidomastoid muscles, and flexors of upper limb. And muscles that are prone to become weak are prenui, tibialis anterior, vastus medialis and lateralis, glutei, rectus abdominis, external oblique, rhomboids, lower portion of trapezius, and extensors of upper limb. As a description of somatic dysfunction, here I would like to discuss lower cross syndrome. That is a very common example of somatic dysfunction. We can say that some of the muscles in this region, they become tightened because of continuous overactivity, and some of the muscles, as they are not active very often, they go into the inhibition phase. Thoracolumbar extensors, dorsal side crosses with the tightness of iliopsoas and rectus femoris, and weakened muscles are abdominals and also the glutei, both medius and minimus. So as a response of somatic dysfunction in the lower cross syndrome, postural compensation that happens all across the body. So think about the body from the side and draw true diagonal lines across the greater trochanter. One of the diagonal line is for the tight muscles that are overactive. They become very dominant in movement control. These muscles are lower back extensors and hip flexors. They are pulling body into shifted position like in anterior pelvic tilt. Now the muscles on the other side of the diagonal line are weak or phasic muscles that usually do not become very active so quickly and consistently, and they are core and gluteal muscles. So the hips are flexed in standing position, and the lower back muscles are also flexed in the standing position. So we can say that hip flexors and back extensors are tightened and short, while abdominals and hip extensors, that are gluteus maximus and medius, are tightened. There are two tools that are very important for the identification of somatic dysfunction. One is end-feel and the other one is length tension assessment. Here we can see a diagram that is showing initially the neutral position of the body and then the active motion that a patient can perform on either side. The extent of the end motion that a patient can perform actively is called as physiological barrier, whereas the passive motion that is performed by a therapist or a doctor is called as the anatomical barrier of motion. These are the normal barriers. Let's discuss about the end feel. There are some normal end feels when you move the body to the end range and you can feel tissue approximation. That is a soft end feel. You can see the example of knee. Hard end feel is bone contacting a bone. Firm end feel you can feel when a muscle is being stretched, or a ligament is being stretched, or a capsule is being stretched. So when we talk about the abnormal end fields or the abnormal barriers, they tend to move the muscle into a limited movement position. The type of motion barrier is determined by end field. Normal end field is the normal range of motion, both physiological and anatomical. Whereas, if we talk about the hard capsular end field, that indicates pericapsular hypomobility, or a jammed or pathological end field indicates the total hypomobility of the joint. Elastic end field indicates the presence of hypertonous structure, whereas inelastic end field indicates fibrosis. Muscle length tests are standardized procedures where we see the length of the muscle being changed with movement. This is so far for the somatic dysfunction. I hope you understand it very well. Thank you.